as a therapist, we have to kind of contain that internal reaction that we had so we can be present with our client, because how we might react personally is going to be different than how we react professionally. We have an ethic in our field around providing effective care, but it's also least restrictive care, right? And that can apply to sexual health conversations. Right? We see it in standards around finding the level of care that's going to work for our clients. That we don't make recommendations for inpatient when outpatient will do. We don't prescribe the highest amount of a medication when a lower amount will do, right? Because we're trying to protect client autonomy while at the same time providing effective care. So how do we do that with sexual health conversation? If shame and scolding was an effective treatment approach, then maybe we would be talking about it, but it's not. But there is research that suggests that compassion is motivating.
But the definition I particularly like is I think of sexuality as a body-based experience rooted in the interpersonal, wherein psychological meaning gets wrapped around physiology. And then we locate this in a social context that includes many generations of family history, a religious and value system, and our cultural narratives around pleasure, around excess, and around addiction. Affairs are less about sex and more about desire and longing, being desired. It can also be about incomplete grieving and existential crisis. You know, is this all there is to life? I'm turning 60, is this it? It can be about unaddressed sexual frustration. So behavior is meaningful. The individual may be trying to self-soothe or reconnect with a lost part of themselves. The partner may then try to take control, and it's important to figure out what exactly is the problem.
This notion of compulsive sexual behavior, of sex addiction, it's in pop culture, right? We see this in popular media. We see this in popular discussions. It's in movies, it's in films. Sometimes it shows up on TV shows. It's a common idea. Obviously, you guys are all aware of it, and you're also aware that it's not just popular from a pop culture perspective. There's also a large body of treatment-focused literature. There's books upon books upon books on how to treat compulsive sexual behavior, on how to treat sexual addiction. So what we were arguing was not that moral disapproval just makes you feel addicted. What we were arguing was that moral disapproval interacts with how often you're engaging with a behavior. And that interaction of moral disapproval and frequency of the behavior is incongruence, so that people that disapprove of a behavior are more likely to interpret any engagement with that behavior as being an addiction.
This is meant to be also in a collaborative style. Like, I'm not dictating any of this. This all will come from them. When I'm working with this in person, right, I might draw this out on a piece of paper and then I hand it to them and then we talk about it. If I'm online, I have them pull out a piece of paper and draw this themselves. And what I tell them is like, all right, we're going through this process. Let's revisit what your vision of sexual health is, because that actually might have changed from that consultation appointment to now. So we revisit what their motivation, where they're moving toward. And then we start to develop some commitments around their behavior.